It's just a huge honor for me today to be podcast interviewing Dr. Jim Douglas Bates, DDS, MD, oral and maxillofacial surgeon at Texas Oral and Maxillofacial Surgery, Diplomate, American Board of Oral and Maxillofacial Surgery, Fellow American Association of Oral and Maxillofacial Surgeons, Fellow International Team for Implantology. Man, do I got a treat for you today. This guy's amazing. He was born and raised in Lubbock, Texas, attended Texas Tech University before graduating with honors both from the University of Texas Dental Branch at Houston and Texas Tech University of Medicine. He completed his residency in oral and maxillofacial surgery at the University of Texas Health Science Center in Houston and is a diplomat of the American Board of Oral and Maxillofacial Surgery. In 1995, Dr. Bates founded Texas Oral and Maxillofacial Surgery, which is currently celebrating 15 continuous years of Joint Commission accreditation as an office-based surgery facility. He is a fellow of the International Team for Implantology. The reason that I got him on the show, and I can't believe he took the time to come on, is his orthognathic surgery cases are just mind-blowing. I mean, they're mind-blowing. And I'm also surprised you came on because after the Arizona Cardinals just destroyed you this week in Dallas in front of your hometown, I thought for sure you would just cancel and say, I'm not talking to any Arizona Cardinals man today.
I'm very much on the fence. I honestly don't follow the Cowboys, but I'm sorry to hear that they lost anyway.
Oh my gosh. So I mean, your cases are shared on social media. I don't even know if you're aware of half the cases. I see cases all the time on social media, and it's like, I know who did that, and it's you. First of all, I want to start with Dallas, Texas.
Sure.
You're a DDS, you're an MD. This is October 10th. A lot of people are saying that COVID is having a comeback, accelerated cases. You would know far more about it than I would. What do you think? Do you think we're going to have a fall surge?
I think we will have a small fall surge. We are having one in Dallas already. August, September dropped way down, and now we're starting to see a rise again.
Now, are you the dentists are mostly scared about, they made us close down for 2 months.
Right.
So if you got a 12-month business and you get a donut for 2 months in a row, that's really hard on the income.
Exactly.
The profit, because you're still going to pay your bills. You
Right.
just don't want to have any profit. Do you fear that maybe a second shutdown will be coming? That seems to be the biggest fear on dentists' minds. Is that a possibility?
I think it's possible. In Texas, we have a governor, Governor Abbott, who's a pretty reasonable guy, and he's the one who shut us down in the spring, along with our county judge, Judge Jenkins, and we were closed for about 7 weeks and then allowed to open back up. I think if we see cases continue to rise as they are right now, we may see a closure of schools, we may see a closure of movie theaters, but I doubt if we'll see another closure of healthcare practices.
I'm only worried about the bars, but that's just me. You didn't mention bars. How did the bars look?
Bars are, they're open, but they allow only for limited attendance.
Well, I can sit in there alone. No
okay.
problem. No problem. If you got to go to his website, it's texasoms.com. Texas OMS for oral maxillofacial surgery. Go to /orthognathic surgery. My illusion of you is that's all you do. I mean, what percent of your practice is orthognathic?
It's probably 60%.
Yeah.
And the other 40% is TMJ surgery, reconstructive oral surgery, bone grafts, guided tissue regeneration, dental implants, taking out impacted wisdom teeth, dealing with impacted canine teeth, doing distraction osteogenesis. Corticotomies are getting to be a really big deal for surgically accelerated orthodontic treatment.
Like, I feel like I'm interviewing a mermaid riding a unicorn. I mean, this is a very rare. I mean, my oral surgery friends over the last 30 years here in Phoenix told me, they said, orthognathic surgery is 90% of my stress and 5% of my income. I'm just going to delete it. And
Right.
they've never been happier. And then there's guys like you who
Right.
just said, I'll keep taking them. Is oral surgeons doing what you're doing? Is that trending downwards? Is it becoming
It's been
more
trending downward for decades, yes. Ever since managed care came along in the late 80s, early 90s, the reimbursement from insurance companies for covered procedures has been extremely low. And it's a sisterhood with medicine. It's the same way medicine and general surgeons and OB-GYNs are being handled. And so most oral surgeons find exactly what you said. It's 90% of my headaches and stress and 5% of my income, so they quit. There are a few of us that have continued to maintain it and actually grow our practices as a result of that. And we're able to do that because insurance companies don't pay for everything on a patient's treatment plan. And the rest of it is where the reimbursement is adequate enough to make it worth your while. Plus, that's what I enjoy doing. That's why I went into oral surgery, was specifically to do orthognathic surgery.
So you were just you were raised with so much pain and suffering, you just wanted to stay and get more? Is it
That's
your
right.
glutton for punishment? So when you say, first of all, when you say managed care, I think that's so funny because managed care, it's like they always name something on the enemy, like I always say, when they advertise 2 scoops of raisins in every box of raisins brand, there's no raisins. When they advertise a warranty on a car, it's no good. It's like the free trade agreement. It's like, okay, when you spend 6 years and it's 1 million words, if free trade is like, hey, you two are free to trade. So
Right.
it's not free trade. It's the exact opposite of free trade. It's the most highly regulated, crazy stuff. But do you still participate with the managed care fee schedules?
I do for covered services, and that's the key phrase. So much of what we do to get a patient ready and to do the actual surgery is considered not covered. So the patient's responsible for it. The part that is covered is so small that we can manage that and live with it, and because of volume, we can make up for it.
Interesting. So orthognathic surgery, is that just basically Lefort 1, 2, and 3?
It's really primarily Lefort 1 in multiple segments. We typically do a horizontal maxillary osteotomy at the Lefort 1 level below the nose or at the nose, and then segment the maxilla vertically so that we can expand the maxilla. And then we move it up, down, forward, back, wherever it needs to go. A Lefort 2 involves including the nose, and a Lefort 3 involves including the cheekbone. So those are pretty rare. And then there's mandibular surgery, which is primarily sagittal ramus osteotomies.
So I'm so old, I can remember when they were doing subperiosteal implants and ramus frames.
I remember those. I remember those very well, and I actually wrote an article on alternative implant systems, and subs and ramus frames were really popular back in the 80s.
Well, I want to get right to the chase. When you're talking to a dentist, a hygienist, they're getting their teeth cleaned, they're talking to the hygienist, they talk about, I don't have a chin. When I smile, my liver shows. And when they start talking about the surgery, everybody freezes up because they're worried about paresthesia.
Are
they? Yeah. And is that compared to 1980s to 2020, 40 years later, is there significantly less paresthesia than there was in the 80s?
Yes. We know that across the board, if you take all comers from teenagers to people in their 70s, orthognathic surgery causes a temporary nerve injury in virtually 100% of patients. But in 80% of those patients, it completely resolves. Now, isolated maxillary orthognathic surgery at the Lefort 1 level results in numbness of the skin of the midface, but it always comes back 100%. The lower jaw from the mouth to the neck has about a 20% long-term neurosensory dysfunction rate, which means simply that people probably don't gain 100% of their sensation back about 20% of the time. Now, that's usually in older patients because nerves heal very, very, very slowly, and even more slowly in older individuals, and they may never completely recover in people over 50 or 60.
I heard a scientist say on television one time that take Superman. They say Superman's spinal injury was actually healing. It just would have taken a couple of centuries for it to work. Is
Right.
that what you're kind of saying, that it's
Exactly.
healing, just not going to heal in his lifetime?
Right.
Now, are you doing this out surgery, or is this a hospital based? Or
I would say most of our procedures are inpatient, meaning that patients spend one night in the hospital, and they're there not truly on an inpatient basis. They're there on an observation basis. According to the government, if a patient is discharged within 23 hours, don't ask me why, but it's 23 hours, then they're considered observation. If they stay more than that, they're inpatient. So most of our patients are on observation basis. They spend one night in the hospital and go home. Our single jaw patients, like if we just do an upper jaw or just do a lower jaw, we're doing those on an outpatient basis where the patient goes home the same day, or we do it in the office under general anesthesia. Because we're an accredited office-based surgery facility, we can do that and send patients home with a nurse to watch them overnight.
Wow. And I guess the anesthesia is one issue. I guess the better issue would be, have you ever asked them, if you had to do this all over again, would you still do it? Or knowing what you know now, a year after the surgery, would you not recommend it? What kind of feedback do you get on that?
That's a really good question, Howard. I ask every patient that very question at the end of their treatment. After their orthodontic treatment, after their surgery, after their cosmetic dental treatment, whatever they're going to have, when it's all said and done, I always get them back for a final set of records, photographs. And the last thing I always say is exactly what you said. If you knew, knowing what you know now, would you do it again? I would say that I've had one patient in the last 30 years say no. Most people are very, very appreciative of the outcome. People can breathe better, they can talk better, they can chew better, they can swallow better, they're free of pain. We relieve obstructive sleep apnea. Those patients in particular are very appreciative because they don't have to be on CPAP or a mandibular advancement device. Those people who are in pain from temporomandibular joint problems are very, very thankful to have undergone treatment.
So I hate to put you on the spot like this, but someone under orthognathic surgery, under oral maxillofacial surgery, asked, hello, can anyone explain to me what is the Dirk-Leck procedure and how it is used to correct a prognathic mandible? Is it considered orthognathic surgery? And if yes, where can I find information about this procedure? Thank you. Have you heard of that procedure?
You know, I have to confess, I have not. Say it again, Dirk-Leck?
Dirk-Leck, D-E-C-K-L-E-R-K.
Boy, that's news to me, Howard.
And then I heard then the guy replied, he goes, a Leclerc procedure is performed on the zygomatic arch, most often for chronic condylar dislocations. Not sure if any of this is a name for prognathia. Do you think when he said Dirk-Leck, he's thinking all Leclerc?
Leclerc, yes, that's probably what he's thinking. The Leclerc procedure is actually an eminectomy, where we make a horizontal osteotomy in the articular eminence right in front of the temporomandibular joint and down fracture it, as I recall, unless I'm misunderstanding him, down fracture it to prevent the condyle from dislocating repeatedly.
Okay, so humans, the number one goal of a species is to survive long enough to reproduce.
Right.
So is most of this, I call it the Peacock Syndrome. When I grew up in Kansas, my neighbors had peacocks. They were beautiful, but they were loud and noisy and crazy. But I understand it when animals and birds of feathers go out of their way to look as pretty as a peacock. What percent of what you're doing is just to make me look prettier, so I have a better chance of reproducing and having offspring, versus form, function, chewing, breathing, all that?
That's a really solid question. I think it depends on who's looking at it. From a patient's perspective, that's very high on their scale of importance and value. On my scale, it's probably down in the middle or lower third. Everything we do is a combination of function and aesthetics. There's nothing that we do, including dental implants or taking out wisdom teeth or anything else, that's not a combination of function and aesthetics, particularly orthognathic surgery, because function and aesthetics are so intimately connected. They're so interconnected that the way a patient's jaws are formed will affect their function very prominently. And if we fix one, we fix the other. And so commonly, it's been shown, studies have shown, that the main reason patients seek treatment is for aesthetics. But their improvement in form and function are what they really are thankful for at the end.
My gosh, I got so many questions I could start asking you on. I just want to go in. Is there anything else you want to talk about orthognathic surgery? I mean, for our listeners right now, 25% are still in dental school, and pretty much all are under 30. Podcasting is a young thing. They're on TikTok and Instagram. Not are you on TikTok or Instagram or any of that stuff?
I am on Instagram, not TikTok.
But are you on it personally or just marketing for your business?
Just marketing.
Yeah. Everybody thinks I'm big into social media. They don't realize it's only for Dental Town. It's not for, if I want to call my mom, I just call my mom. I don't FaceTime or Facebook her or something. But on orthognathic surgery, what do you think the kids in dental school and the dentists fielding questions from consumers about that? Because on these Instagram and social media influencers, I mean, gosh, they're doing butt implants, calf implants. But it seems like the most common question that I see on social media and asked by the patients is when they don't have a chin, should I get a fake chin or should I get the lower jaw surgery?
Right.
And then the opposite is the maxillary. When they smile and half their liver shows, they don't know if they should do to periodontist cosmetic surgery or should do orthognathic. So could you answer those two questions?
Well, certainly. There are degrees of correction that we can accommodate. In other words, we can compromise on somebody with a really short lower jaw and small chin. We can do a chin implant or do a sliding genioplasty, which is actually a better procedure, and not do the full-blown mandibular advancement. It's less surgery. It takes about an hour to do a chin operation, and it's clearly outpatient. And patients say, yeah, I want that. I don't care about my bite. But when we look at these people critically, they always have malocclusions. And that's one of the things I'd really like for your really young dental students and young dentists in practice to really be aware of is to look for those occlusion changes. Look for those malocclusions, those severe class 2 occlusions, those open bites, those class 3 or crossbite or underbite malocclusions. Those are the things that where they can really make a difference in a patient's life. If they say, hey, you know, you've got a really bad occlusion, in addition to your weak chin, why don't you go see the oral surgeon, take a look and see what they can do. And then we have the opportunity to discuss with the patient, work them up for 2 plans, one for the whole shooting match, so to speak, the upper jaw, lower jaw, chin, and then the second one for strictly cosmetic reasons that won't address function, won't address their occlusion, won't address their pain, but will very effectively address their cosmetic concerns.
Nice. TMJ, I even hate to bring this up because it doesn't seem like the endodontists really have any big feuds, or they don't really fight over much anything. Pediatric dentistry, I can't believe after 30 years, they finally got an issue to argue over with silver diamine fluoride.
Right.
But TMJ, I don't think there's anything they agree on. I mean, it's kind of like international world religions. I mean,
well,
and they
we have some good data now that's pretty solid. We know that most patients don't need surgery. Most patients have myofascial pain in the side of the head and the side of the jaw, and not joint pain. And those patients who don't have an internal disc displacement are really the only ones who need surgery. Now, the ones with myofascial pain usually have a malocclusion and are usually nocturnal bruxers and may have sleep apnea. And all of that goes together. Most of those patients can be managed non-surgically with muscle relaxants, non-steroidal anti-inflammatory drugs, and splint therapy. But the splint therapy has to be really good splint therapy. I don't do splint therapy, but I can evaluate and recommend good splint therapy, and a splint needs to be hard acrylic and not flexible and not soft and rubbery, not an Essex retainer. It needs to have anterior guidance with cuspid disclusion in all excursions, and that's a good splint. Now, if those patients have pain that's in the joint itself and they're popping and clicking and they say that hurts, those are the patients that we can help with surgery, with minimally invasive surgery that's very successful. Arthroscopy is about 70% successful. Arthroplasty is about 95% successful. A minimally invasive arthroplasty through a modified endural approach on the inside of the ear with an incision that's about 1.25 inches long allows us to pull the disc back and tie it down to a Mytech mini implant, and that's a 2-hour operation. Patient goes home the same day and takes a few days off.
Nice. God, I got so many questions to ask you. I don't know where to start, but when you were talking about the TMJ and the myofascial pain and things of these sorts, when I got out of school, there were only 9 specialties, and now we've added some more. We've
Right.
added oral facial pain, oral medicine. What are your thoughts on that? Was that a good thing? Do you when you have a TMJ patient, you're doing a workup, do you send them to an oral facial pain guy, or?
Right. You know, I often do. Because I'm a surgeon, that's what I do, that's what I like to do, that's what I prefer to do. I don't do splint therapy, I don't do iontophoresis, I don't do physical therapy, I don't do massage or laser or any of the other things that can be done non-surgically. I think that kind of management is effective for about 90 days. I think you ought to try it for 90 days and then come to a decision. We're either going to keep doing that or we're going to go to surgery.
When I was little and got out of school in '87, what I see as oral medicine, I just would have sent him to my oral surgeon. I mean, I'm not going to send him to the pediatric dentist. How is oral medicine? If you were a young kid and you just started your practice and you're working as an associate, what would make you want to send this person to oral medicine or oral facial pain versus we used to throw them to the oral surgeon?
Right. And I'm very thankful for oral medicine being a specialty, particularly oral medicine, because those are people that really focus on soft tissue lesions, kind of traumatic ulcers, dry mouth, sore tongue, the kinds of things that I can't really diagnose or treat. I can't operate on a dry mouth. I can't really help them. But oral medicine, a dentist trained in oral medicine that's done an appropriate residency or fellowship really has a whole cadre of support mechanisms, particularly those that are in training centers, that they can throw at the patient and, something will stick. Something will help them, but they can do little tongue biopsies. They can have them change their mouthwash. They can have them change their dentifrice. They can have them change their oral habits. And that's not stuff that I can really do. I mean, I'm not very effective at that. I'm not very good at it. I still see patients referred to me for dry mouth, sore tongue, but I refer them to our local dental school stomatology clinic. To my knowledge, we don't really have anybody in oral medicine yet in Dallas that's interested in doing those cases.
Well, do you hear that, kids? You're in the middle of a pandemic. You don't know what to do. Go specialize. And because the trend line to young kids, one of the biggest mistakes I see, which doesn't make sense to me, and, live your own life. You weren't born to live Howie's life. But in 1900, there were no specialties, and healthcare was 1% of the GDP. By 2000, there were 9 specialties in dentistry, 58 in medicine, and it was 14% of the GDP. Now it's 2020. It's up to the 88 dentistry is up to 12 specialties. It's up to 17% of the GDP. I mean, we're not going back. And then I hear these young kids that say, well, I want to learn how to do Invisalign and implants and endo. And I love their youth and enthusiasm. But when you live in a country that mails out 40,000 healthcare journals a month, you can't be a jack of all trades.
That's true.
And even Texas, your home state, you're in Texas. There was even a lawsuit where we're talking about specialties where the Texas U.S. District Court sides with the American Academy of Implant Dentistry on specialization lawsuit. These guys with the AAID were saying, well, we specialized in implants. And it went to court, and the defense was, well, the ADA doesn't recognize it. And the judge basically said, well, that's a membership organization. That's not a regulatory agency. I mean, so what, do you think that dental implantology will eventually be a specialty? Will orthognathic surgery eventually be a specialty? Where do you draw the line on these?
Right. I do think that dental implantology will and is already seen as becoming a specialty by lots of folks. I don't think orthognathic or TMJ surgery will, just because there's just not that much demand. I mean, it's not enough to support that many dentists. But I clearly think dental implants are a huge market share for dentistry, for endodontists and periodontists and oral surgeons and general dentists and who knows, prosthodontists. And I wouldn't be surprised if they are successful in carving out a dental specialty. There are a couple of organizations, the AAID you mentioned, then there's the Academy of Osseointegration, that have fellowships in oral implantology that are legitimate, and they have boards, and they take a test, and they're, legit all the way. I think I wish them well. As long as they advance the outcomes and improve care, I think I'm all for it.
And you're involved with another one. You're involved with the I had it right here in front of me. The ITI, the International Team for Implantology.
Yes.
Tell us about the International Team for Implantology.
Well, the ITI is an organization based in Europe, and it goes back decades, many decades, to the very beginning of implantology. Not only dental implantology, but orthopedic implantology and many other kinds of implantology. It goes back to Per Ingmar Brandemark. It really was one of the very first European organizations to really develop the research to back up the legitimacy of osseointegration of dental implants. They did the basic research. They published it. They have a journal, the International Journal of Oral and Maxillofacial Implants. And they're very solid. They have published textbooks on a variety of implant procedures, from very beginner to very advanced. And it's an invitation group. I was very, very honored to be invited to join them. It's a really super organization.
You know, one of the things that has always helped me is you know, that we're one species. We have the same problem. Like I like architecture because when I go around the country, I mean, take something simple like a bathroom, a shower. I'll never forget when I was taking a shower in Austria. I mean, it looked like it was designed for the space shuttle. I mean, it had more plumbing and knobs and backup features, and I'm just like, oh my God, these guys are serious engineers. But what I like to see in dentistry is is the same doctor looking at the same patient with the same disease, and they're treating it differently. Do you see any variances? I mean, little things like, you know, some countries it's all air-driven handpieces, other it's electric handpieces. Do you see any oral surgery variances where you think we're all really smart oral surgeons and we're seeing this differently? Any things like that?
I do. In Europe, it's a little bit different system. If you are an oral surgeon in Europe, really limits his practice or hers to procedures on the inside of the mouth. In other words, they really don't do orthognathic surgery or TMJ surgery or facial trauma surgery or cosmetic surgery. They pretty much specialize in dental implants, soft tissue grafts, bone grafts, guided bone regeneration, things of that nature. Then there are maxillofacial surgeons who are dual degree dentists and physicians, and they're primarily involved with more advanced orthognathic and TMJ reconstructive surgery and facial cosmetic surgery. So it's more of a division in Europe than it is here. Here in the States, back in the 70s, our organization, our national organization, decided to change its name from the American Association of Oral Surgeons to Oral and Maxillofacial Surgeons, and we've kind of got the big tent of both true oral surgeons and dual degree oral and maxillofacial surgeons under one umbrella. And I think I like it better this way because I can go to meetings and learn about dental implants and teach on orthognathic and TMJ surgery. You can't really do that in Europe. If you're an oral surgeon in Europe, you're limited on what you can do.
So the one of the things that kids point out, and it's very obvious in America, in our country, they come out of dental school, they want to learn more about oral surgery, but they look at all the available education, and it all seems to be aligned with a manufacturer, like, the big ones, Straumann or Nova Biocare or whatever. And they just routinely ask year after year, well, do you have to pick an implant system? Because if I go take this course, it comes with, 10 implants or a starter kit and all this stuff. And then, of course, they're going to ask guys like you, are you agnostic to implants, or is it just easier for you to only work with one system? What would you tell a young kid in Texas who wanted to get into implants?
I would say get really good, legitimate training at a center. I think the weekend courses put on by the manufacturers are okay for people who've had 5-10 years experience in dental implants if they want to add a system. But I think to get unless they're getting this in dental school now, and I honestly have to say I don't know, I haven't been on a dental school faculty for the last few years. But if they're getting it in dental school, basic science, exposure to multiple systems, then that's fine. If not, I think the dental schools, the continuing education departments, really need to supply that academic legitimacy to implant training. I've been disappointed. I know exactly what you mean. Every manufacturer has a course, and you can't be an expert in everything. You can't do 8 different implant systems in your office. It's too expensive. You have to buy a system. You have to buy a separate everything. You have to keep an inventory. It's just not practical.
How many systems do you work with?
I work with one system, and I work with Straumann because it's connected to the ITI. That's really my connection to Straumann and the ITI. I had the honor and pleasure of being invited over to Europe years ago when Straumann first introduced the ITI into the United States, and we got to tour the facility. And so I have a long-standing relationship with them, but I'll do a Nobel case if a restorative dentist or prosthodontist wants a Nobel implant. There are other systems that are based on, but really don't have the backup of the older systems that are I just am a little uncomfortable using a lot of those systems.
And I really I had the old CEO of Straumann, Marco Gadola, on the show, and that was an amazing. But it seems like Straumann's also been doing kind of like a big Wall Street M&A. They've been buying Keep It Simple in Israel, or was it Keep It Simple?
I think it was Keep It Simple in Israel. They bought Neodent
in Brazil,
in South America, and they bought one of the orthodontic aligner companies. I think it may have been ClearCorrect or one of those.
Yeah.
Could be wrong. But Straumann has its hands in lots of stuff.
And I remember, so this is a, let me set this up for a second. When Pierre Brandmark, who passed away, when he came to America, I remember you could only go to the course if you're an oral surgeon. And if you snuck in, you were asked to leave. And it was just oral surgeons, and that might be product placement, introduction. He wanted to get his protocol out right. And it took years before periodontists were allowed to come to the party. And now it's opened up to everybody. But
Right.
the young kids, they're afraid to ask you, "Can I come watch you do an implant?" Because they're thinking that you would say, "Well, that's how I make my living. You go make your living somewhere else." And then they get on an airplane and they fly across the country and they go pay $3,000 for a weekend course. And then when they get in trouble and they step in quicksand, that guy lecturing 3,000 miles away isn't there. And I always tell them, when I wanted to learn more about endo, I drove over to the greatest endodontist I know and just asked if I could, stand behind his assistant.
Right.
Is that really a thing? And now also with all the big meetings canceled because of the pandemic, everything's virtual. People are saying, "Well, where am I going to get a hands-on course?" And I said, "In what?" And they go, "Endo." I'm like, "There's no endodontist in Dallas?"
Right.
Really? You have to fly to Georgia?
We have an obligation as professionals, as people with advanced education. We have to share our knowledge, our experience with the new generation coming up. That's our responsibility. It's not optional, in my opinion. And yeah, I get young dentists all the time who say, "Hey, can I come watch you take out a set of wisdom teeth? Can I observe you placing some dental implants?" And I am more than happy for them to attend physically and to help them get started in that any way they can. Now, that's, it's a little bit different when it comes to orthognathic surgery or some of the other things, but most of the young dentists that I see that are calling me to say, "Hey, can I come watch?" are interested in two things. That's wisdom teeth and dental implants. And I'm more than happy to share any knowledge or experience of mine with anybody that's properly trained. I'm not going to bring in an accountant and show them how to take out wisdom teeth.
Do you have any slide lecture presentations?
I do. I have many.
Oh my gosh, I'd drive to Dallas to have you put some up on Dental Town. They just love
Really?
it. Oh, I mean, we put up 400 courses. They've been viewed over 1 million times, and what they tell me is that it's cheaper to take an online course than it is to take a cab to the airport to go fly to a convention. And now the conventions have been taken away. I'm still confused about Greater New York in 2 months after Thanksgiving. They still haven't officially canceled or anything. And
I've gotten some notices from them. It looks like they're going to try to still have it.
Wow. But the beginning of the show, we were talking about a spike increasing, and New York. I don't want to get. I never want to talk about religion, sex, politics, violence. But Taiwan and New York both have the same population. And Taiwan had 7 deaths, and New York had 34,000 deaths.
Right.
So I doubt they're going to have the Greater New York meeting of people flying in from around the world. But I don't know. Stranger things have happened.
I hope they don't.
Here's a question that I think only you could answer. A lot of kids wonder, they extract a tooth, so they bone graft or not, and they just keep getting all these different messages.
Right.
So she's pulling a tooth. When would you recommend bone grafting, and when would you recommend not?
Well, almost always. I'll put it that way. I think unless it's a situation where the dentition in general is just totally hopeless, and you're going to go with an all-on-4 or zygomatic implants or pterygoid implants, you really need good alveolar bone within the dental arch. Now, you can take out one tooth at a time and bone graft that, or you can take out a bunch of teeth and bone graft that. But I think most of the time, with the population that most of us are dealing with, we're dealing with single tooth extractions on pretty healthy people, and they're eventually going to want an implant. If a patient says, "No, I'm never ever going to have an implant," then there's no point in doing a bone graft. But I don't think many people will take that stance. I think most patients will understand the need for a bone graft. I think it ought to be simple. I think it ought to be fast. I don't think it should be complicated or difficult. There are lots of products now that are available specifically for that purpose that are very effective and simple and easy to use and don't have that much cost to the procedure.
So, sometimes they hear that if they bone graft, it only makes sense if you place an implant within a certain amount of months. True or false?
Nah, I don't buy that.
You don't buy that?
I think if you're using, it depends on what you're bone grafting with. If you're bone grafting with allogeneic real human bone, that's true. It's only valid, it'll resorb in about 6 to 18 months. But that's not what I use, honestly. I mean, I will use anorganic bovine bone that's cortical. I'll use typically BioOs or BioOs collagen as a product that is resorbable, but very, very slowly resorbable, and is ready for an implant in 6 months. I will also very more commonly use a product from Israel called Ogma Bond Apatite, which is a bone cement. And it comes in a syringe, and you squirt it in the socket, and you close it up, and you're done. It's very simple, and it's resorbable, but very, very slowly resorbable.
And a lot of these bone grafts, it's more expensive per gram than heroin, cocaine, and crack.
That's true.
Are the prices coming down any?
Well, they are for some products that I haven't used. I see products advertised where you buy a plug of bone and collagen that's designed to go in a 2-socket for, $75. Now that's probably more than it should be, but it is what it is. And I think patients should understand that you use that product, there's a markup, it takes time to place the product, it's longer than a regular tooth extraction. I think patients appreciate and understand that.
I went all the way through dental school, graduated in 87. They never even mentioned sleep. Sleep medicine, I mean, it wasn't even a thing in the 80s.
Right.
Some people are saying, Stanford's saying that this guy that just died, William Dement, MD, PhD, known as the father of sleep medicine, dies at age 91. Is that the father of sleep medicine to you?
Well, no. He's the fathers of sleep medicine, as far as surgery is concerned, are based at Stanford. There's a guy named Guilleminot, Guill, etc. And other people at Stanford really developed the protocols for the surgically successful treatment of obstructive sleep apnea. The gentleman you named, I don't recognize, but I suspect if he's the father of sleep medicine, he's probably a pulmonologist or a sleep medicine physician who's not a surgeon.
So you would say it's Dr. Christian Guilleminot?
Yes, Guilleminot.
Guilleminot? Is that French or French or French?
Boy, you got me.
you always know when it's French. So what is, when I got out of school, the first I heard about sleep medicine, snoring, all that, is my ENT got a carbon dioxide laser and was rotor-rooting out of the back of the throat.
Right.
And then, just like I think is most important that you ask all your patients later, if you had to do it all over again, would you do it all over again? And they all said no, because they lost their sense of taste and smell. And they said they're like eating cardboard. So how's the journey of sleep method? And now a lot of people are saying, well, you don't want to wear a CPAP all the time. Go get orthognathic surgery. So what's your update on sleep?
Okay. As far as surgery for sleep, we have a very, very high success rate with orthognathic surgery. They really don't call it that. They call it telegnathic or telegnathic surgery. And the name for the operation is the maxillomandibular advancement. But it's not the gold standard. CPAP is the gold standard followed by mandibular advancement oral appliance therapy. But as far as surgery is concerned, there are really a couple of options. One is soft tissue surgery, like what you described, the roto-rooter, the palatoplasty or uvulopalatofaryngoplasty or UPPP, and that has about a 50% success rate, and that's pretty low. I mean, that's not very effective. And then there's tonsillectomy, which is a little bit better, tongue reduction with radiofrequency, which is a little bit better, but maxillomandibular advancement has a 90% success rate in eliminating obstructive sleep apnea.
That's you couldn't ask for more than that. I was just wondering, any other things on the 12 specialties? I mean, oral. We talked about oral medicine, oral facial pain, and oral medicine.
I'm glad those guys are there. I love having a place to send patients that don't need surgery.
The one I'm most thankful for is a pediatric dentist. I mean, what went wrong in your life where your best choice was to hear screaming, yelling children for the rest of your life?
Right.
I mean, I don't know why they do it, but I'm so damn glad they do it. I see you're doing liposuction.
Mm-hmm.
Is that in the face, or
Yes.
are you doing bellies and?
No. I don't do anything below the collarbone. Now, there are people that are trained with my training that do that. I'm happy for them to do that. I don't want to do it. I do submental and cervicofacial liposuction, particularly in people with mandibular retrognathism, people with short lower jaws that have an obtuse chin neck angle that would benefit from that. And it needs to be, the good candidates for that are younger people with a little bit of isolated extra fat, not the 300-pound obese sleep apnea patient that's 55 and already has platysmal striations. The ideal patient is the younger patient with a little bit of extra fat under their chin.
And I'm just curious, this might sound bad, but is that mostly all girls getting this done, or are there guys getting that? Or
I see men more often going for that and seeking that out. Yes.
You see more and more men doing it, but
Yes.
what percent are men today?
It's probably 70-30 women to men.
Something that's interesting. And the first, when any patient was telling me they get a facelift, I always tried to talk them out of it because it looked like their face was in an elevator. And the first facelift I saw that was good is, and the oral surgeon explained to me, he goes, the non-oral surgeons, they make incisions in the skin and pull the skin back and it looks crazy, but they were getting underneath and pulling the muscles back.
Right.
And they, I have to tell you, even though I'm biased, I'm a dentist, but it seems like the oral surgeons do better facelifts than the plastic surgeons.
Well, that's my feeling as well. I don't do facelifts, but the best results I've seen are from people who do a full thickness facelift, not just the superficial skin facelift that we used to see back in the 70s and 80s.
Okay, final question. You're getting called for patients. You're a busy guy. There's this still long-standing dispute on Septicaine anesthesia. There's still a lot of dentists that believe that it could cause a paresthesia if you give a mandibular block, and then other people just say that that's just not true. Do you use Septicaine on a mandibular block?
I don't use Septicaine, but not for that reason. It's just not it doesn't fit my personal preference. I like something that has a very fast onset and a very long duration. Now, that drug doesn't exist right now. And so I use a combination of carbocaine, which is just very fast onset without any epinephrine or vasoconstrictor. And that carbocaine mandibular block really kicks in very quickly so that the mandibular teeth are very numb. Then I followed that with Marcaine with epinephrine, bupivacaine with 1 to 200,000 epinephrine, and then they're numb for 6 hours, and they didn't even feel the shot. And that for wisdom teeth, for tooth extractions, that's my go-to protocol.
And the other controversy is for pain meds. Do you still prescribe opioids, or?
We had a problem in Texas when they kind of blocked us from prescribing hydrocodone and some other class 2 and 3 narcotics. I use a drug called tramadol in conjunction with a high dose of ibuprofen. I use 800 milligram ibuprofen tablets. I tell patients we're doing biphasic pain control. We're doing one phase to raise the threshold of pain. We want you to take it whether you want it or not regularly for the first 72 hours, and then follow that up with breakthrough with tramadol, the narcotic for breakthrough pain, and that's very effective, and it's much more easy to prescribe than hydrocodone.
Final question. Some kids are scared to learn how to place an implant, but they're removing wisdom teeth. Some older guys say, well, it's actually harder to pull a wisdom tooth than it is to place an implant.
No kidding.
So where would the extraction skills be on a young 25-year-old dentist where you thought, okay, if you can pull that tooth, you can place an implant to replace a maxillary second bicuspid with an implant?
I think you have to be comfortable with drilling in bone. I think that's the limiting factor. I think if you're just using forceps to extract teeth, that's one thing. But if you have to get out a drill and irrigate and keep the bone healthy, and you know how to do that, then you can do implants. It's very straightforward. Using a drill to cut a tooth or to cut bone is harder and more difficult than placing an implant. So if you know how to do one, you know how to do the other.
It was a huge honor for you to come on the show today, Dr. Jim Douglas Bates, DDS, MD, out of Dallas, Texas. And if you ever want to write an article in Dental Town magazine or put an online C-course, we would just love it. Thank you for educating us general dentists on everything new in oral surgery. It was just an honor to podcast you.
My pleasure, Howard.
All right. Have a great day. Good luck on your surgeries today.
Thank you.
All right.
Bye-bye.
Bye-bye.